Welcome to the International Federation of Fertility Societies webinar series on endometrial receptivity. I am Linda Giudice, immediate past president of the IFFS, and my co-moderator today is Dr. Marcos Horton, president-elect of the IFFS. Today we focus on the window of implantation and clinical tests in this first webinar of 2 webinars, the second of which will be next Thursday. I am delighted to introduce our first speaker, Professor Nick Macklin, who will be speaking to us on the window of implantation, displaced, disrupted, both, neither. Professor Macklin trained at the University of Edinburgh for his medical training as well as his laboratory training. He did a fellowship at Erasmus University and also at Stanford. He also has had positions of leadership at the University Medical Center Utrecht, as well as chair of obstetrics and gynecology at the University of Southampton, and subsequently at the University in Copenhagen. He currently is medical director at London's Women's Clinic, and his main research interests are in human implantation, novel markers of endometrial receptivity, and periconceptual determinants of health. Professor Macklin.
Well, thank you very much, Linda. It's a great pleasure to be here and to join this meeting. A great subject to get to grips with, and together with my friend Juan. So I've been asked to talk about this interesting topic of the window of implantation, and to assess whether or not we should be worried about it, essentially, displaced, disrupted, both, or indeed neither. And it's fair to say that this figure has become rather etched on our minds as reproductive endocrinologists as being central to our understanding of what's going on in the luteal phase, what we need to be seeking to achieve, and why. And we're all very familiar with this notion that's been around for many years now, that there is just a very short period of time in the mid-luteal phase when the endometrium becomes open to implantation from an embryo. What I'm going to do today is remind you a little bit of how we landed there, how we've been viewing this over the last few years, what opportunities it's given us, but also some new ideas that we're beginning to get about the significance of this short period. These are my disclosures. And yes, we need to come back and we talk about this window of endometrial receptivity. Now, it has been, it's very much in the air as part of our lives. We believe in it inherently. But its origins are quite interesting. I mean, if you go into the literature, I think the first time we really see evidence in the human, at least, it's been known about in rodents for many years, was back in this paper, 1950. Superbly, it was the very first paper published by Fertility and Sterility, Volume 1, Number 1, 1950. What a great subject for the first paper. And if you're interested actually in how this paper came to be and the work of Noyes, let me start by recommending this really super review in Fertility and Sterility Reports, published in 2020, where the whole story behind the Noyes criteria, which we talk about, was become so central to our understanding of endometrial development, how it came to be. That is for another day, but it is fascinating to read. But essentially, here are some of the figures that were published in that original paper. So that paper, if you look at it, and you can find it online very easily because it was republished in about 2019 in Fertility and Sterility. And there's these beautiful micrographs of these very different aspects of histology of the endometrial surface, the epithelium, in endometrial biopsies taken at different stages. And what Noyes was able to do with the help of his students, his research students who did a lot of the work to identify these, was come to a conclusion that there were not just one, but several features of the epithelium that needed to be interrogated in order to be able to understand essentially how many days of exposure it had had to progesterone. And this quickly found value in the fertility space because it was very quickly seen as a surrogate for receptivity. We've got to remember that that was never the purpose of the noise criteria. It was simply to make some assessment as to whether the endometrium, how far matured it was from ovulation. And here you see how each of these ones changes over days, and you can see it's quite rapid changes. And taken together, a skilled pathologist is able to make an assessment and maybe come to the view that it has been disrupted or displaced or whatever we want to call it. Now, the idea that we might be displacing it as clinicians through ovarian stimulation became evident in a beautiful study from S.K. Day's group that was published in PNAS almost more than 20 years ago now. And this was in laboratory animals, which undergo a very different process of luteal phase changes in the endometrium. Decidualization happens under different controls. But essentially what this very convincingly showed was this idea that the period of receptivity in rodents was very dependent on the hormonal milieu, such that when they were exposed to a steady degree of progesterone in the luteal phase, how long they remained receptive seemed to be correlated to estradiol levels, primarily in the follicular phase. And so when estradiol levels were very low, it never became receptive. When they were very high, it became receptive, but for a very short time. So we might say the window of implantation was disrupted. It was shortened by this exposure to estrogen. And it needed a sort of a perfect Goldilocks level of estrogen in order to maintain the receptivity for up to 120 hours. And this idea was sort of transferred to the human situation, but it wasn't really until a paper published by Kolobianicus and then latterly by Paul de Roy, where we saw some evidence in the human that displacement or disruption of what we might call the noise criteria for determining this period in the mid-secretory phase seemed to be disrupted by ovarian stimulation. And they showed this comparison of the natural cycle on the day of ovulation and the stimulated cycle on the day of ovulation, showing degree of advancement, that here we were on the day of ovulation, but after ovarian stimulation, it was already showing features that we might expect to be part of the window of implantation, at least heading in that direction. And what Kolobianicus was able to show was that when there were markers of this that were very advanced, more than 3 days, there was a correlation with very poor implantation rates. So I remember when this paper came out and we started getting rather anxious.
I'm sorry, can you go to presentation
whether or
mode?
not we should be altering how we manage ovarian stimulation in this regard. But there was a problem, and there always has been a problem with the histological assessment of the endometrium, and that is its subjectivity. So the search arose to see, well, look, is there a more reliable, objective way that we can determine the degree of maturation of the endometrium in response to progesterone? Can we identify another marker that can reliably tell us what stage it is at? Now, I think there's a problem. Can you hear me okay?
Oh, yes, we just need to hit the presentation mode, please.
Okay, goodbye. There we are. Can you see that better? Thank you for that. Okay, I hope you've been able to keep up with me thus far, all the same. So hopefully those slides are a bit bigger. So as I said, that search went on, and it was really Carla Simon's group and indeed Linda Giudice's that really kicked off this whole field of looking at the transcriptomic signature of the endometrium in the luteal phase. And there was a whole range of beautiful publications on this area. And this is one of my favorites because it was 25 natural cycles versus stimulated cycles. Biopsies taken on several days through the luteal phase. And what you can see through here is that there is this sort of clustering of disruption, particularly around about the day HCG plus 7, the very time when we're placing a blastocyst into the endometrium, suggesting that ovarian stimulation was disrupting the transcriptomic signature, and that this is something that indeed might vary and give us a window onto the receptivity of the endometrium. And from that, and from many studies that followed, we got what was really essentially the first, in my view, very exciting clinical test of endometrial receptivity that came out of this work, the ERA test, with which we are all now extremely familiar. And this underwent very, very extensive testing. The theory was very attractive, but the question is, does it work? Does it help identify a problem that we can clinically solve and get better results from it? So off we went, and all those studies came. And Carlos himself carried out the most important one, which was a very large 5-year multi-center randomized control trial, which compared the outcomes in women who had transfer done, and I think one might talk about this a little bit more later, based on the information from the biopsy, in which they looked at the genes and transcribed and said, look, is this endometrium responding appropriately to progesterone, or is it too early, is it too late, is it spot on in the middle? And they randomized people to either receive this information and have their cycle managed by it, or indeed not. And this was the inclusion-exclusion group, and it was a good number of patients that went into the personalized embryo transfer, fresh embryo transfer, or indeed non-personalized frozen embryo transfer. Again, I think one might talk about this. So just very briefly, the results of the intention to treat analysis, which is the one that we tend to focus on in clinical trials of this nature, showed no improvement in outcomes when this approach was used. However, the per protocol analysis did suggest there was a benefit. But there was this question mark about the results of this paper as to what they really meant. And a whole series of studies continued to follow afterwards. I don't have time to go into them, but this was perhaps the one that was most influential in terms of how people viewed the ERA test and its value. And this came from Valencia as well, where they looked at the value of endometrial receptivity array testing after a failed transfer attempt. And what was surprising and for many almost shocking about this paper, particularly perhaps given the irony of its origin, although Carlos wasn't an author of this paper, was that it seemed not to be improving outcomes in these very large numbers of autologous and donor egg transfers. In fact, the live birth rate and the cumulative live birth rate were higher in those patients who hadn't had this information to guide the timing of their transfer, as hopefully being at spot on the right moment in the luteal phase. And logistic regression analysis even suggested that having had the test was a contributor to poorer outcomes in terms of implantation, pregnancy, and clinical pregnancy rates. Now, since then, there have been more papers, some suggesting it's beneficial, perhaps in certain patient groups, and others suggesting it's not. But it does raise, I think, a number of important questions. And that is really the core of my topic today, is that it would seem intuitively, wouldn't it, to be the case that if we can synchronize the transfer of a good quality embryo to that moment in the luteal phase when the endometrium is most receptive, we would expect to see improved outcomes. So we've got to ask the question, well, why isn't that becoming strongly evident from the papers that have been published? Well, it may be the case that some of these patients included in these studies just don't have a problem with the window of implantation, and therefore they're not designed to detect the potential benefit of looking for it. It may be that assessing the implantation window requires the same multiplex approach that Noyes described back in 1950. In other words, just looking at one feature of the endometrium to assess where it is in the implantation window might not be enough. And therefore, it might be better that if we can interpret any of these tests, such as the ERA, in light of others, such as the integrin expression testing, pinapodes, which are still around, people are still interested in those. It may be that we need actually more information to make a really accurate assessment of the state of the endometrium in that implantation window. And the third one, which I'm going to challenge with you on for the next part of my talk, is that perhaps we've been wrong thinking about implantation window as being about receptivity, that the endometrium is only receptive to invasion at that stage. It may have a different function. It may be about preparing the endometrium to make a big decision. So let me start off with my train of thought with this to make a proposal to you to consider. Now, the first element of this is going to be a reminder to you and to all of you watching that probably most of us were not perfect embryos. Many of us might have had slight abnormalities, maybe even small chromosomal mosaicisms, but we made it. We made it through that stress test of trying to implant. And what we're now realizing, using modern techniques of assessing chromosomal abnormalities and aneuploidy in a research setting where we can be much more granular with a higher resolution, is that most embryos, even good quality, morphologically good quality embryos, if you look hard enough in all the cells for something wrong, you will find it in about 82% of embryos. Now, this is using a technique that is different from that used in clinical practice using bulk DNA sequencing. In this case, we actually look at single cells, and if you look hard enough, you'll find something. And what this reminds us of is that us as a species, the humans, are quite different from others in that the rate of chromosomal abnormalities in human embryos is very high. And many of these embryos will be invasive. So this presents the woman who's faced with an embryo coming into the uterus, either through natural conception or through IVF, with a challenge that there's an embryo there that may have invasive potential, but may not be viable in the long term. And the idea that the uterus might have an important role in determining the fate of that embryo once it's breached the epithelium was behind a lot of the work that my group did together with Jan Brozens back about 10, 15 years ago, which resulted in this idea that the human embryo, human endometrium, is not just simply a passive receptive organ, but is actually an active participant in deciding whether or not an embryo should be invested in by the mother or not, through what we termed the biosensor. So that notion's been around for a long time, and since that work has been done, a number of groups have been trying to get to grips with whether it's true, and secondly, how it might work. And the work that, again, Jan Brozens has been doing with other collaborators around the world, I think is beginning, in my view, to elucidate what might be happening here. So if you look at their recent review on human embryo implantation, you'll find a different language being used to describe what's going on. So the idea is that the mid-secretory window of implantation, what we commonly think of as being a receptivity window, opens under the rise of progesterone, and that is particularly so for humans, with a decidual stress reaction, characterized by several processes which Noyes was actually observing under the microscope all those years ago, such as apocrine glandular secretion, stromal edema, and what we now know to be an accumulation of uterine natural killer cells. And this is termed a sort of almost a stress reaction. It opens up. And what is it doing this for? It's preparing to respond appropriately to an embryo that is breaching the epithelium. So I haven't said the word receptivity once over the last minute or so in describing what is going on here. And what we're now learning is that the embryo will be sending out signals to both the epithelial layer, which are then transmuted down into the stromal cells, the decidualized stromal cells, indicating its quality. And there are probably several signals for that, one being proteases, others being RNAs, microRNAs, and several others, which are detected at epithelial level and result in a response in the stromal cells. So good blastocysts will secrete these proteases that trigger endoplasmic reticular expansion and induction of implantation genes, and they secrete these microRNAs that promote migration of pre-decidualizing cells. And what his group has done is been able to identify the different participants in this biosensor, and the key one is these pre-decidualizing cells. And what we were also able to show in our earlier work was that poor blastocysts actually, in contrast, trigger a decidual stress response, probably by producing too many serum proteases as they cope with apoptosis and repair. These are detected by the cells as a proteotoxic stress, which results ultimately in menstruation. So we're beginning to learn now that there is this important interaction going on during this window, which is not simply about being allowing an endometrium to stick to the surface, but is actually assessing whether or not this embryo should be allowed to proceed. And what we're learning now is that this biosensor resides in the balance of two cell types, the predecidual cells and senescent cells, which I haven't got time to go into today, but this balance seems to be important. And interestingly, our old friend, uterine natural killer cells, seems to have a role in maintaining this very balance. And we're beginning to understand a little bit about how they're doing that. Now, how are NK cells involved? Well, NK cells seem to be involved in keeping that balance of these two cell types right. And if that balance is right, then the biosensor is properly tuned. If it's wrong, it might become too permissive and allow poor embryos to implant, or reject embryos that should be allowed to implant. And we're beginning to learn now too the products from the embryo which help support NK cells to clear these senescent decidual cells. So again, for those of you who are interested in the work, I've given you the reference there. Now, what's that got to do with the window of implantation and the ERA test? Well, interestingly, what you can do is you can go and look at the window of implantation or receptivity as measured by the ERA test and look to see, depending on the result of that, whether it's pre-receptive, early receptive, receptive, or late receptive, in other words, delayed or disrupted, whether or not that's associated with any difference in the NK cells. And what you see is, if you look at it fairly crudely, just divided between three, there's a slight hint that those that are late and post-receptive have also got higher NK cells. But if you look at it more closely, you can see, A, this is a very small group, and B, across the range of it, we're not seeing really much of a change there, either in NK cells, the CD56 positive ones, or in other immune cells implicated. So it suggests that looking actually deeper into the endometrium might give us more information, just like Noyes had from looking at several things, rather than just looking at the gene expression. And that takes us to another point to consider, that the window of implantation may just be an epiphenomenon, something that the endometrium needs, a limited period, which ensures that the coordinated embryonic endometrial development occurs so that you avoid the risk of late implantation of compromised embryos. Now, why would we be worried about that? Well, this story goes way back to Wilcox's classic papers in the 80s, where he measured the urine in women who were trying to conceive and was able to determine from hormonal measurements when they ovulated and when implantation occurred. And what he found was that when implantation occurred more than 12 days after ovulation, it almost always ended in a miscarriage. And some of the work that we did, and we published 14 years ago, suggested that a reason for that might be that these embryos are implanting beyond the window of implantation, or indeed the window of selection, when that ability to assess embryo quality may actually no longer be present, that limited period of time. So in this paper, we described the implantation window, connecting in with a window selection, which then followed on. And this paper itself was more about why, if this goes wrong, we might get problems with miscarriage or implantation. But for the purpose of this talk, I just want to sort of nudge you further down the road that when we think about the window of implantation, we're not really thinking about receptivity, but we're thinking about something much more profound in terms of the function of it. And that is just the Wilcox paper I referred to. So one of the figures that we published as a result was to try and visualize this, is that, yes, we're dealing always with a balance between receptivity and selectivity, and this window of implantation is probably about both. And depending on how that balance is, we may get inappropriate implantation of poor embryos or inappropriate failure of implantation of good embryos. And the implication from this is we need to be able to study this in our individual patients to understand it. So I think I've pretty much had my time with you, and I'd like to draw some conclusions from this rapid tour through this complex topic, and I'm sure Juan will help us with it as well. I'd like to put to you that the window of implantation is an important one, but it may be less about receptivity and more about selectivity. And why do I think that? What's the evidence for this? Well, first one is a very obvious one to those of us who've been around a long time in IVF, and that is transferring blastocysts has been a fairly recent phenomenon. For many years, we were transferring day 2 embryos, and day 3 embryo transfer is still normal. And if you look at the most recent Cochrane reviews, there's still pretty good evidence that a day 3 embryos transfer policy can do pretty well. And yet we know day 2 and day 3 for the vast majority of women will be the wrong time for implantation to occur. But the good old embryo just sits around and waits and seems to be able to cope with that, suggesting that having these two aligned is not as crucial, perhaps, for initiating implantation as we thought. The second one is that the application of tests to determine and manipulate the timing of window of implantation have not been convincingly shown to improve outcomes. And we've therefore got to ask the question whether the underlying premise around it being a marker of receptivity is correct, because otherwise we would have expected to have seen more convincing evidence that it was beneficial. And where it gives us pause to thought for is that the primary challenge when you've got invasive but potentially low viable embryos is to prevent the implantation of an embryo rather than to allow one. And that the primary role of the window of implantation may be to support selectivity rather than receptivity. And the work, again, coming from the Brosens group and from others, is refocusing, I think, our attention on what the role is. And that has implications because it suggests what we should be looking to measure and how we might be able to intervene to improve outcomes. So I believe then that we need to enter a new era where the tests of disruption of the window of implantation are more complex. They don't assume that just one element of the endometrium is enough to look at. So the original era test may still have a role, but complemented with others. And that these others should now focus on measuring the functional markers of effective decidualization rather than just pure endometrial dating, largely based on epithelial appearances. And the tests of the window of implantation are themselves only likely to be part of the story, as I'm sure Juan will tell us. It's only part of what's going on. And this is a slide which I sometimes show just to remind us there are so many reasons beyond the embryo why it might not implant. It could be that the cavity is hostile, endometritis, secretion contents, pH and oxygen. There may be inherent receptivity problem, as some transcriptomic studies have identified in women with recurrent implantation failure, also including our own work in this field. Or the embryo has initiated but not completed implantation, and this may be immune activation issues or indeed a disrupted biosensor function. So I think where we are now is a moment just to sort of ask ourselves whether we've been barking up the wrong tree a little bit with the way we think about the window of implantation. And if we look at it a different way, we might have a second era, which is much more convincing. Thank you.
Thank you very much, Nick, for a fantastic talk. I'm happy to say that we have 197 people registered and connected now. It is my pleasure now to introduce Juan Garcia Velasco. Juan is the Chief Scientific Officer of IVIRMA Global and Director of IVI Madrid. He is Professor of OBGYN at Rey Juan Carlos University, where he conducts the master degree program in human reproduction, and he has published extensively in all matters in reproductive health, including, of course, endometrial receptivity. So, Juan, welcome and happy to hear your talk.
Thank you so much, Marcos. It's a real pleasure to be today in this webinar talking about this fascinating topic. And it's a pleasure to share the stage also with my friend Nick, because he has made a perfect first lecture to introduce what I'm going to say. And it's basically discuss about this clinical test for receptivity or receptive endometrium, because there has been a lot of noise, a lot of data, and I think a little bit of clarification. But as we just heard from Professor Macklin, maybe the complex is more, the story is more complex, or it's a little bit more tricky than just testing and moving progesterone one day plus or minus. If I could have the, yeah. I think in the era that we practice today, we try to individualize as much as possible. We know patients are different and they demand different treatments. And if we don't individualize patient care, we may lose pregnancies, because we know we need to be adapting our protocols to the needs of every patient. And things do change. We have the Nobel Prize winner, Bob Dylan, saying that as the present now will later be past. We would rather be alert, and even the things that we truly believe may be the scientific truth today may be an old concept tomorrow, and we have to be fully aware of this, because these things do happen. There are papers that at the time of the ERA, which was one of the most popular tests to investigate endometrial receptivity, voices at that time already were saying, well, maybe not, or maybe this is even worse, as Nick just mentioned. And again, ideas are to be challenged, and I think we have to be honest and acknowledge what data tell us rather than beliefs. So my idea is to introduce briefly the concept of endometrial receptivity as it was clearly explained before and attached to the ERA test, and show some of the retrospective studies, the randomized trials, relevant meta-analysis on the topic, similar on a subset of population, which is recurrent implantation failure, and a few conclusions. I think Nick made a nice overview of endometrial research. It all started in the 50s. This first paper by Noyes that we have been using for years, the Noyes criteria, was what a great start for FNS to publish this paper. And then through years, a lot of work has been done on single molecules, looking at interleukin-1, alpha B beta 3. I think all of us have heard a lot about this, and probably one of our chairman today, Professor Linda Judy's work extensively also on these molecules, trying to identify the most receptive endometrium. Then transcriptomics came into play, and some of these receptivity tests were designed using transcriptomics. Then it was like a big hype of this test, and then data started to be controversial, and this is where we are today. The ERA in particular was a test designed to investigate the peak of receptivity of a patient, and it was an array of 238 genes, and we could dissect, let's say, the population of these patients being pre-receptive, receptive, of post-receptive. So that was for clinicians, a very simple test. You just take the biopsy and you understand if you are putting the embryo at the right time or not. And the first paper published with patients was actually with difficult patients, with patients who had failed at least 4 times with 4 high-grade embryos, at that time non-PGA tested. And the group of Carlos Simon identified 85 of these RIF patients with 25 controls. And when the endometrium was tested and the transfer was adapted to the ERA test, you could almost normalize the results. There were patients who failed many times, and they had at least 5 previous failed cycles. And they got a 46% success rate after embryo transfer. So obviously numbers are small, but as usually happens, initial studies are always very, very optimistic, let's say. Then the test was fine-tuned, and you could define beyond non-receptive in yellow or receptive in green. You could have like early or late pre-receptive. You can have real receptive or late receptive, and you can identify, as numbers grew, different success rates. And even you could identify when implantation happened late, a higher rate of biochemical pregnancies, which correlates well with the Wilcox concept that Nick just explained us. But it's true that the numbers that you can see here are still small. So when you look at retrospective studies, not all of them were suggesting that this was a very useful test. In fact, this paper coming from Israel showed in 53 patients that were tested with ERA that success rate were more or less similar. And this was one of the first papers showing that maybe ERA was not as useful or as expected. A slightly larger paper by Ristenberg in 2021. Again, they looked at probably a better selected patient population. These are women undergoing the first euploid embryo transfer, so at least you have consistent quality after the biopsy. And whether they had the embryo transfer with ERA or without ERA, just looking at that, the success rate was the same. But when the test was receptive or non-receptive, if you look at the data retrospectively, again, they couldn't find any difference. So again, interesting data to look at. If we take the concept a bit wider and we forget about testing the endometrium and you just look at the data of how many days of progesterone you give to your patient before embryo transfer, this study done in UC Brussels in 2021, they were brave enough to transfer embryos after 5 full days of progesterone versus 7 full days of progesterone, which is quite a challenging study to perform today. And when they moved progesterone by 2 full days, they couldn't see any difference in the live birth rate. So again, maybe timing was not such a crucial concept. There are similar studies looking at progesterone hours, and again with euploid embryo transfer, so it's a bit more consistent. If you look at the capacity to predict the outcome, especially predicting ongoing pregnancy, it was useless to look at the hours of progesterone because it didn't seem to be so impactful. So probably, again, reinforcing the concept that timing in general for all patients is not that relevant. And this paper has been mentioned by Professor Macklon before. It was a retrospective analysis of a large database from EVI, and they combine a lot of patients that had been tested with after one failed cycle at least. It combined single embryo transfer and even double embryo transfer at that time, cleavage stage or blastocyst stage. So it's not a really pure population analyzed here. And obviously the classical inclusion criteria to avoid any other reasons for a failure. And interestingly, it didn't seem to improve anything, the endometrial receptivity test. You can see the cumulative live birth in IVF patients with fresh or frozen embryo transfer, and in green with personalized embryo transfer according to ERA. And if you take the similar data with donor oocytes, again, you can see the live birth rate with or without PGTA in egg donation. And again, personalized embryo transfer didn't seem to improve the outcome as we might expect. So this was 2022 when we were challenging the concept that we truly believed 10 years ago that it could make a big change. And then as it should happen in science, data has to be validated out of your center, of your hospital, your environment. And retrospective data came from the US this time, this is the Doyle study, retrospective analysis in 307 embryo transfer that were adjusted by ERA versus a large control group with conventional preparation. And whether the ERA showed receptive or non-receptive, again, there was no difference at all in beta HCG, clinical pregnancy rate, or even live birth rate. And I think this was, again, quite shocking, but again, the data has to be validated in a prospective randomized trial. And here is where randomized trials come into place. This was the first study done by our group, Carlos Simon, first author. It took 5 years. It was a very complex study, and it was published in 2020. And there were 3 groups here comparing personalized embryo transfer versus frozen embryo transfer versus fresh embryo transfer. 569 patients were assessed for eligibility, and then groups were about 140 patients per group. If you look at the pregnancy rate per transfer, there were no difference here. You can see that the pregnancy rate was comparable, implantation rate was similar across groups. So we could say, well, there's no difference. If you look farther into the data, the cumulative live birth at 12 months was significantly higher in personalized embryo transfer. P-value was close to significant, and it was better whether you compare it with fresh or frozen. So it may show a little bit of value here. However, this study was criticized, as you can see in this comment that was published subsequently to the paper, because the dropout rate was really high. There was a huge dropout rate in these patients. It was difficult to convince them to follow what had been randomized. So with a 50% dropout rate, it's difficult to trust that the conclusions were based on the data, on the design. And there was also a little bit of unbalanced distribution among groups, among other criticisms. So again, one single trial, again, does not prove anything, whether it's valuable or not. But then this study was published in JAMA, and I think this was for us the eye-opening study, and was the definitive study. Again, Doyle, first author, Kate Devine, senior author. And what they did is randomize patients in a multi-center trial, double-blind, and it was a one-on-one randomization. It was very simple but very good design. Single euploid blastocyst, high quality, of course, with euploid tested by PGTA, no RPL, no PGTM, normal uterus in terms of morphology. And about half of the population seemed to be non-receptive according to the test. But this data shows that whether the transfer was timed according to the receptivity test, or the embryo was transferred according to conventional protocol without taking into consideration the receptivity test, the outcome was exactly the same. Whether you look at biochemical pregnancy, biochemical loss, clinical pregnancy, live birth rate, and even ectopic. So it doesn't seem to benefit doing this test to improve the outcome in a general population with single euploid embryo transfer. And obviously, if you put in a study, in a meta-analysis, different studies, and most of the studies are in a direction, the outcome of the meta-analysis will convince us that this is true. And in this meta-analysis published in 2022, combined 8 different studies with very different sample sizes, almost 3,000 women analyzed, and you can see the forest plot here. It doesn't cross the unity, so no significant value of doing the endometrial receptivity test before a frozen embryo transfer. And what about if this could be beneficial in a specific subset of patients in recurrent implantation failure? Well, again, you have data from Boston IVF here coming in a retrospective analysis. They showed what was the benefit in the general population, again, whether you transfer according to ERA, adjusting progesterone, or whether you transfer in non-tested patients, the outcome was exactly the same. And if you look into this subpopulation of women with 3 or more prior failed embryo transfer, so this could be a population of recurrent implantation failure, again, you can see that the odds ratio it's similar. So no benefit, again, no benefit of adjusting progesterone according to the test. And how frequent is this recurrent implantation failure? Maybe is this a population that could benefit if it was a real population there? But more and more, we are convinced that implantation failure, it's a problem with the embryo and not so much with endometrium, even though, of course, we could do better in the first cycle than 65% implantation rate. This is a paper published by our group last year in Human Reproduction, taking a huge sample size of more than 120,000 patients and looking at the outcome of 5 euploid blastocyst transfer, one after the other. So it seems that every time you transfer an euploid embryo, your pregnancy rate keeps increasing. And you can see a success rate of 65% in the first transfer, up to 98% after 5 euploid transfer. Of course, not every couple is able to produce 5 euploid embryos. And of course, if we understood better this concept, which is a complex process, maybe we could do better than just being satisfied with this 65% success rate. Ideally, we would like to be in the upper 90s. But it's true that if there was something limited in the endometrium, if we continue transferring embryos, implantation rate would be a plateau. It wouldn't increase if there was an issue with endometrium. And the only thing that changes from number 1 to embryo number 5 is the embryo itself. So we believe that there's more to it than chromosomes in the embryo. There are things that we don't fully understand, and this is the reason why doing exactly the same, sometimes the embryo implants or not. And as Nick mentioned before, we could have an issue not only with timing, but maybe this pathological window of implantation, maybe this disruption in this molecular dialogue between the embryo and the endometrium. And we, up to date, we don't have a way to analyze this unless we go for trial and error, unless we transfer embryos, and if a pregnancy does not happen, then we may speculate that there is an issue with endometrium. But up to now, there is no test to understand this upfront. So finally, to conclude, what should we do? Well, we could take the easy road, which is take the guidelines. And I'm in Spain, but we could be in the US, or we could be in a global perspective as we are in the IFFS setting. But if they guidelines from any large society, most of them would agree today that endometrial receptivity tests are not recommended. But we know that guidelines are not ideal. They tell us what is the framework that we should work, and they give us a strong background and strong support to the decisions. But it is true that according to the data today, endometrial receptivity tests do not seem to be so useful. Actually, we published this paper in American Journal of OBGYN, and it was a SWOT analysis explicitly analyzing what we mentioned today. What are the pros and cons? What are the benefits? What are the threats? And what are the opportunities? Because there's still opportunity to investigate further on the endometrial receptivity test. And this is the reality in our center. When we were starting the studies in early 2010, the number of biopsies in my clinic increased dramatically as the papers were showing a benefit. And we could see in the retrospective and observational studies that the data was promising. So we're very enthusiastic about doing this test. And then after the randomized trials were published, as you can see, the number of biopsies decreased dramatically, because today we don't think it's a good option for the patient. So I think we move forward due to previous efforts. We heard about the noise criteria published in the 50s. We have seen a huge amount of work done by a lot of research groups, including many of the people in this call and many of the presenters today and the discussions. And this famous phrase of, we walk on the shoulders of giants, I think we have to acknowledge the work that has been done by previous research teams from Noyes and to all the groups that have been working on transcriptomics and looking into the endometrium, because until very recently, everything was only the ovary and the oocyte sperm and the embryo, and that was it. And more groups are looking into the endometrium, because there are things that we don't really understand and we have to focus on it. So we need to acknowledge that what we are capable of doing today is based on work from previous research groups. Also, we need to adapt to technology, and we have to acknowledge when it works and when it doesn't. This is a great example. Kodak, it was probably the biggest company in photography in the world, and what is Kodak today just disappeared because they did not adapt to the changes. So even if we have a good tool like transcriptomics, that could be great to understand a lot of molecular issues in science, I think if it doesn't work, we need to acknowledge that, probably this is not the ultimate and final goal. This is not the best test, and maybe we need to move forward and either wait for new technology or new methods to investigate endometrium. And as we all know, if we want to reach far, we need to work in groups. Isolated people do not go very far today. We need to establish these multi-center trials, connecting basic science from the lab into translational research with clinicians. And this is the only way we can really offer a value to our patients. So finally, I think, and going back to the topic itself, I think the available data up to date does not suggest that routine testing of endometrial receptivity will help us to optimize the best day for embryo transfer. I think today to suggest a receptivity test for a patient is controversial, and the data does not seem to support it. Modifying the hours of progesterone exposure previous to embryo transfer based on transcriptomic data does not improve reproductive outcome, at least as we understand it today. And we may expect ERA or similar test 2.0. Maybe. We know there is technology being developed, looking at different technologies. There is AI algorithms combining static images from 2D scans. So I'm absolutely convinced that in the near future, we'll have new tests that we will need to validate before we offer them to patients. But there are many things still to understand from the endometrium. Thank you very much.
Thank you, Juan. Wonderful presentation. I think this is so challenging, the issue of clinical tests. And I was thinking if we could summarize it as, if there is, my first question will be to Nick. Is there now a translation of those studies about NK cells into some clinical validated test already, or what's the timeline for that?
Yes, thank you. Well, there's been a number of things have been patented from the embryo side to sort of measure the products of embryos which might be detected by the endometrium, such as the proteases. Not by me, I hasten to add, but they have been done. There is work from the Brosens group on a test to look at the quality of decidualization. And this has been shown in initial studies to be quite promising at identifying when a selection problem might be the reason for recurrent miscarriage. The idea being that women who have recurrent miscarriage, a proportion of them may simply be allowing embryos to implant, which they shouldn't. They have now developed a test for that, which is now going, they've just got a huge grant, Innovate grant in the UK to take that forward into phase 3 clinical trials. So there is movement in this field. But, I think the lesson from the era is a very salutary one for us. I think it does show us how desperate we are for a good test of endometrial receptivity. And the work of the last 20 years has certainly moved us in that direction. So, yeah, I like one. I'm pretty optimistic that we're going to have something that's an era two going forward.
Thank you.
May I just make a comment also?
Linda,
First of all, I want to thank both of you for really just superb presentations and getting us all to be thinking. It's very encouraging, built on all the data that have already been generated, to have the realization that we need to look outside the box. And some of the tests that you have mentioned, Nick, like the decidualization assay, the numbers and functionality of uterine NK cells and other immune populations, and of course other modalities, are very promising. I would also offer, as we look at Juan's picture of the bicyclists working in teams, to also think about data integration, since there is such a huge amount of data out there, if you will, to be able to look at potential interactions of the different individual items that most people focus on. So very exciting time for the future. Thank you.
Thank you. I have a question here. Maybe Juan, Sergio Pascolini from Argentina is asking, probably referring, I will summarize it, referring to the variability of tests or between cycles or in natural cycle or stimulated. Do you think there could be the ideal test to be done just before the transfer, like the day before, maybe a few hours before, and that would maybe change from a previous test that has been done to the patient?
Yeah, thank you. It's a great point, actually, because this is the main issue with testing the endometrium, taking a biopsy, where you cannot transfer the embryo that particular month. So you may have I don't know, whatever test you have, and it says, yes, it's perfect. Then next month, due to this cycle-to-cycle variability, the endometrium may not be exactly the same. So I'm aware of devices and tests that are being developed in a way that is not so invasive. You have to go in the uterine cavity, but you can respect the endometrium. So you can have the information without disrupting the endometrium and be able to transfer in the same month. This is the dream test that we all want, but as far as I know, there's nothing yet available.
Thank you. Any comments on the other test related? We haven't talked about microbiome, and it's a whole topic, but do you think there's value in the addition of, in the case of the ERA test, the EMAN and the ALICE? What do you think about that? What are your thoughts?
Well, yeah, as you said, I can tell you my thoughts. I don't think there's a definitive answer to this, because those two topics, I think we have jumped into diagnosing with our specific criteria and over-treating probably without a clear diagnosis. So today, we are a bit confused on what is the impact, if any, on reproductive outcomes. So I think it's so easy to treat with antibiotics and with probiotics that you can buy anywhere, that a lot of people are doing it. A lot of patients are willing to take anything without having a clear diagnosis. And I think we are over-treating many of these patients. So actually, what we are doing right now is, in fact, doing a large trial. We need to study more than 1,000 women to understand if the microbiome actually has any impact at all in implantation with ejaculate embryos. And if it does, then we will be able to understand which patients need to be treated and how. But up to now, I think most of the tests will give you an information that is valuable. And if the patient has failed once or twice, he will be so frustrated, maybe as much as the doctor treating the patient. And jumping into a probiotic is so easy that probably, I don't know if we'll ever have a clear answer to this question. Chronic endometritis is a similar situation. There's a huge lack of agreement between the diagnostic criteria, between the hysteroscopist with the image and the CD138 or the MEM, the MAM, different antibodies that you can try with metagenomics, with endometrial culture. And there's a huge disagreement between the diagnostic criteria. There's even papers showing that no matter how many plasmatic cells you have per high power field, 1 or 5 or 10 or none, has any impact at all. So I think this is the right time to do the proper studies, try to avoid over-diagnosing or over-treating our patients, and try to convince them to participate in trials that will help them and probably future patients to have a proper criteria to diagnose and treat.
Thank you. We have maybe a few minutes left, but there is some questions about the progesterone levels. We will be dealing with this next webinar, of course, but maybe Nick can answer if you think there's any association between these receptivity or selection tests with maybe progesterone levels. I know there's a big discussion on the peripheral progesterone levels.
We published a paper on this a few years ago in the American Journal of Reproductive Immunology, where we carried out ERA tests and progesterone levels and NK cell testing. In fact, I showed you a figure from the paper earlier. I didn't show the progesterone estrogen data. And what we didn't find was a correlation between the progesterone level in the mid-secretory phase and the result of the ERA test. And I think a number of studies since then have also borne that out, that there doesn't seem to be that correlation, because the idea would be that by adjusting the progesterone exposure, you might improve the result of the ERA test. And we haven't seen evidence that that's the case. And, there could be a whole range of reasons for that. And I think we've tackled many of them today. We're not seeing that correlation.
Okay, thank you. So I'll give it back to you, to my chair today, Linda. I think we're closing, so please.
Yes, thank you. So I want to thank the speakers once again, and also the audience. And we have a second webinar, which is next Thursday, same time. And that will be on endometrial receptivity conditions for frozen embryo transfer and approaches to optimization. And our speakers will be Dr. Elena Labarta and also Dr. Kate Devine. And then one more slide, if you can advance that, please. We would like to welcome everyone to attend the IFFS World Congress in Tokyo in April this year, April 26th through 29. And we welcome everyone to come. It's just a marvelous program of reproductive medicine, from genetics to endometrium to environment, and on, as well as reproductive health across the globe, because we are a global organization. So again, I want to express my thanks, and also to thank Dr. Horton for his leadership here as well. Thank you.
Thank you all. Bye-bye. Thank you, Nick, and thank you, Juan.
Thanks very much.
Thank you very much. Bye-bye.
Thanks.